a radiologist, so also from the clinical information, always take it a little bit with a grain of salt. I'm really a physicist, and I want to share with you a little bit of the background of arterial spin labeling MRI, the new kind of research that is going on, and then of course also the clinical use of arterial spin labeling MRI. And of course we have to be open about our potential conflict of interest, and myself and my group receives research support from Philips, and I'm also an invited speaker for Philips. So if we're thinking about hemodynamic measurements by MRI, we can more or less split it in two different kind of approaches. The first is really look at the blood vessels, so MR angiography, which we use for visualization of the large arteries, but also measurement and quantification of the flow in the big arteries. And I will be talking a little bit about that today. But then, of course, on the second hand, we have perfusion imaging, where we really look at the tissue level, how much blood is flowing through the tissue. And this is, of course, interesting from both a biological but also a clinical perspective, because it determines how much blood and therefore also oxygen and nutrients are really going to the tissue. And we know that when there is pathology or if our brain is active, then the amount of oxygen and nutrients will change. And that's, of course, we can then use to better understand brain diseases, but also to perform diagnosis imaging. And this is, of course, a crucial difference. Whether we're looking at anatomy, like this on this one-weighted MRI, and sometimes if we're looking at this anatomy, we are actually forgetting that there's an underlying physiology taking place. And these are, of course, the beautiful kind of images that the anatomist can make of the vasculature. And we see this delicate bed of vessels that really make sure that there is enough oxygen and nutrients going to the tissue. And that's brain and the link, of course, between these two is that brain function really is correlated with the amount of blood that goes to a certain brain region. The nutrients and oxygen are coming in from the arterial side, exchange with the tissue, and then, of course, we have the venous side. And so why is this interesting? And now, first of all, if there's a deficit in the hemodynamics, then frequently this is already an early marker of brain disease. And frequently we already see that the hemodynamic situation is changing before there's really pathology visible on the MRI scans. Then if we see like that there's a whole flow territory showing a difference in perfusion, we can, for example, think about whether there's a stenosis or an occlusion of one of the brain feeding arteries. And also can tell us that a certain disease like inflammation is affecting a certain part of the vascular tree. Already mentioned, if we have occlusions or stenosis, we want to see whether there are collateral vessels, making sure that enough blood goes to the brain tissue. Also, we can look at the dynamics. How quickly is the blood actually flowing through the brain tissue, and how quickly is it arriving? And we have learned that if blood is arriving very slowly, and you can still argue it's still arriving, so it's okay, there's still enough nutrients and oxygen going to, but we actually have seen in many, both contrast agent, but also non-contrast agent methods, that if the blood takes a long time to travel towards the tissue, that's also a quite severe pathological situation. And finally, already mentioned in the introduction, we can think about and look at the blood-brain barrier. And we know that this blood-brain barrier is this very specialized barrier that we have in the brain to protect our neurons from toxic elements from the blood not going into the tissue. And the blood-brain barrier integrity is, of course, very important if you're thinking about tumor imaging, but also for Alzheimer's and epilepsy, we would be interested in it. So how can we measure perfusion with arterial spin labeling MRI? And the nice thing and the brilliant thing about ASL is that actually we use the blood itself as a tracer. We more or less turn the blood itself into a contrast agent. So how are we doing that? I've shown you the image before. Let's imagine that we want to measure the perfusion in the white part, showing in the white part. What we do is that we actually invert the magnetization of the blood below the imaging slices. So we put the magnetization in the opposite direction. Then we wait 1-2 seconds for the inverted blood to actually flow into the brain tissue, and we acquire an MR image, like shown over here. Now, this image is not a perfusion image yet. This is a combination of static tissue with an inflow of inverted blood. So to be able to actually depict perfusion, we need a second scan. And the second scan is exactly the same scan as the first. The only thing is that we don't invert. Let's see whether I can get a pointer. No. Yeah, that we don't invert the inflowing blood. All the rest of the sequence is exactly the same. So if we also acquire an image over here, we will see that they almost look the same. But if we subtract these two images, the signal from the static tissue will be subtracted out, and we will only see the difference between these two images. And that is the inflow of inverted splints during this, what we call a label image. And you get an image like this. Now, of course, my colleagues are always joking with me, saying that we just measure noise. But if you average this, say 30 times, you will actually see that the SNR is increased, and you get a good quality images out, and you can actually also quantify the perfusion in milliliters per 100 milliliter per minute. And of course, we already see the gray matter, white matter contrast, and of course, we know that in the cortex, the metabolism is much higher, and therefore also the blood flow is much higher. So this is your basic ASL experiment. And we switch on a labeling plane with which we invert the inflowing spins for about 2 seconds. Then we wait about 1.5–2 seconds, where we give the inverted spins enough time to travel in the brain tissue. Then we acquire an image. Subsequently, we acquire the control scan. We have the same situation, but we don't invert the inflowing blood. We still wait, they say, 2 seconds, and we acquire a similar image. And if we subtract these two images, we get our perfusion scan. And so this is the basic ASL experiment. Now there's one complicating factor, and I think this is essential if you start using it in your clinical practice to understand this. We are inverting the inflowing blood. That means that we lose the magnetization with the T1 of blood due to longitudinal relaxation. This means that if we wait 3 seconds, we only have 60% of our label left. And so you see that we very quickly lose the tracer that we have created. So if we think about how long can we wait after we have labeled our inflowing blood with reading out the images through the brain tissue. If we wait very short, say 100 to 600 milliseconds, we will see that our label is still in the big arteries. We are measuring an angiogram. If we wait around 2 seconds, you can see that now the label has flown into the brain tissue and actually exchanged into the tissue. So we're doing perfusion imaging, but if we wait too long after labeling, our label will have decayed and we only measure noise. So when you are using ASL, you always have to think about this scheme. Where am I? Also, what kind of signals do I see in our images? If I use a short delay, I'm doing angiography, and I can make it 4D MR angiography, showing very nicely how the label spins are entering via the circle of Willis, the brain, and subsequently going through the vascular tree and feeding the whole brain. If I have a long delay, I'm doing perfusion imaging, and we see how much blood really reached the tissue, and therefore a measure for the delivery of oxygen and nutrients. Now there's one problem, and that's that we see frequently in patients that this blood is actually arriving very slowly. And so what we frequently see in more severe patients is kind of this situation, that even if we wait, say, 2 seconds after labeling, we still see that the label is in the brain feeding arteries. And if I would image later, I would only measure noise. And so you see that there is not really a very good perfusion phase to do the measurements, but the fact that I see the label in the brain feeding arteries is giving me very important information about the hemodynamic condition of the patient. So you can call this kind of arterial transit time artifacts. You can say it's an artifact, but you can also say it's information. And so be very aware of these kind of artifacts in your images because they are essential when you are reporting. And so this is, for example, an example from here in the Leiden clinic. This was a middle-aged patient with a brain tumor giving radiotherapy and also chemotherapy. And you can actually see that the label is still in the big arteries. And so the label was still on its way to actually perfuse the tissue. So in 2015, with the Perfusion committee, Perfusion study group, we actually have written this consensus paper on how to acquire your ASL images. And this actually also led the vendors to actually implement this consensus sequence into the commercial systems. We first summarize that we can use different ASL techniques. We can use pulsed ASL, which we use a very short pulse, but over a large region to invert our blood. We can use P-castle or pseudo-continuous ASL, in which we create a labeling plane that inverts the blood flowing through the plane. Therefore, we have to switch on this labeling plane for much longer, say for 2 seconds. But it's a much thinner labeling plane. And there was also, and still is, the new kid on the block, velocity selective ASL, where we actually do not labeling based on the location, as in the pulsed ASL and P-castle, but based on whether spins are flowing or not. Now, the consensus paper stated that pseudo-continuous ASL should be the clinical workhorse and would be the first choice when you start using ASL. It also stated that you should switch on the labeling for around 1.8 seconds. After the end of labeling, use a labeling delay, this pause to let the label spins enter into the brain tissue of 1.8 seconds. That you use shoot background suppression and a segmented 3D readout. But again, your vendors will frequently provide you with a correct sequence. Also in this recommendation papers, we are a little bit more providing more specialized settings when you're measuring in different kind of populations. And so for the normal condition, we use 1.8 seconds, but if you're measuring neonates, you label a little bit longer, but also, for example, when you're measuring elderly subjects in which you maybe expect this kind of delayed arrival of your label, you can also increase your post-labeling delay a little bit. And we were still a little bit conservative when we were writing this consensus. At the moment, I think we are more comfortable to increase this post-labeling delay also to 2.2, 2.4 seconds, and maybe also increase your labeling delay your labeling duration a little bit, say to also 2.5 seconds. We think it may actually provide slightly better images. So this is a first example how such a perfusion scan looks like, and it's actually an example that I scanned with one of my PhD students. And actually, when we were looking at these scans, it was quite clear that in the right hemisphere, he measured lower intensity on our ASL scans than on the left hemisphere. Now, the first response is that you actually look at the brain-feeding arteries, whether there's a stenosis or occlusion. And for us, that would be quite shocking because this was supposedly a healthy volunteer. And I'm showing this you as one of the problems with ASL, or one of the pitfalls. Because actually we scanned this subject because we're developing a new sequence in which we could also measure how efficient the labeling was. And this was work done together with Shenzhen Chen from Tsinghua University in China. And if you're actually looking over here in the labeling efficiency, you can actually see that on the right internal carotid artery, the labeling efficiency was much lower than on the left internal carotid artery. So the fact that we see hypo-intense signal over here is not due to a stenosed or occluded brain-feeding artery. It's just because of a poor labeling efficiency, which, for example, can be caused by some dental work. So if you see this, think about pathology, but also think about maybe it's an artifact of our sequence. And you could recognize it over here because the kind of decreased signal is really in the kind of flow territory of the internal carotid artery. So now I will give you a few more recent developments on what researchers are working on in ASL. And the first thing that we have been working on is multi-time point ASL. And so in the consensus paper, we say just wait for 1.8 or 2 seconds and then acquire one image. But actually what is also very nice, as shown over here, is to see how these label spins arrive in the brain and how they spread out. And there's actually quite a bit of information in these kind of images. And some radiologists also really like to look at these images to really understand the way that the blood is flowing through their patients. And the important thing is that actually these kind of acquisitions, if you're thinking about quantification of perfusion, can be just as time efficient as a single time point measurement. And so this is an example of a clinical case that I got from Makoto, who is a clinical scientist in Japan, and he measured this together with Dr. Togawa in Kyushu University in Japan. And here you see that we use again ASL as a angiography sequence. And already you can see that arrival in the kind of M1 and M2 looks different. And this was a patient with Moyamoya disease, where of course we are aware that there will be kind of many different pathways for the blood to actually feed the brain. Now you can also measure this with perfusion imaging, and then you get these kind of movies. And again, I think this kind of movies gives you really a good understanding of how the brain is being fed by the arterial blood. Moreover, from these scans, you can make parameter maps. The ATT map, the arterial transit time map, shows you how long it does for the label spins to actually arrive in the brain tissue. And you can very clearly see in this subject, these two regions with very prolonged arrival time. You can also quantify the blood flow, and then we see that there's also a lower perfusion in these kind of regions. So I think this is a very elegant way to get more information than just the perfusion. And how this ASL can also help in the workup of Moyamoya can also be seen in these slides that I got from the group in Utrecht, who actually measure the blood flow under baseline condition, but then they give an intravenous bolus of acetazolamide as a stress test. Acetazolamide is dilating the vasculature and should therefore increase the blood flow. Then you can measure a second ASL scan, say after 10, 15, 20 minutes after giving acetazolamide, and you see already from these two images that the blood flow has increased in quite a number of parts of the brain, but not in this part. And so you see that there's kind of a regional even steal where you see that the blood flow decreased because the resistance of the vasculature bed in the other parts of the brain has actually decreased, and therefore more blood is going into these regions at the cost of the blood supply in this region. Note also that on this CBF map, we already saw some transit time artifacts. You see this kind of hyperintensity showing that the labeled spins are still in the brain feeding arteries, which is a sign of compromised blood flow. So that was already a sign that something was going on. And based on these scans, they decided to go for surgery. So another application of this multi-time point ASL is something that is a study that I did together with Lena and in collaboration with a group in Spain. That's not this graph, by the way. This is a very famous publication by Ituria Medina in Nature Communication in 2016, in which they were looking at different markers in the different stages of Alzheimer's disease. And you have the healthy controls and then the early memory complainers, late memory complainers, and the late onset AD. And if you look at when are certain markers changing, you see that this, what is it, brownish orange curve is actually the first to change and actually therefore one of the earliest markers of AD. For example, before amyloid beta PET. And this orange curve is actually the ASL data. And so ASL is maybe already very early on able to actually play a role in the Alzheimer workup. And that's what we did with the group of Carlos Falcom in Spain. And we used both a single post-labeling delay ASL sequence and a multi-time point ASL sequence. And you can see that in the cognitive unaffected A-beta negative subjects, you have the highest blood flow that decreases in the cognitively unaffected by the A-beta positive subjects, and a decrease further if you go to the cognitive impaired A-beta positive subjects. Also shown on the left-hand side, where you see the brain regions that are actually involved are showing decreased blood flow in these kind of different stages. Also, you see that the multi-time point ASL sequence seems a little bit more sensitive than the single time point post-labeling delay ASL sequence. So the second new development I want to talk about is flow territory mapping. And because one of the nice things of ASL is actually that we can either label all blood vessels at once, or we can actually only label a single artery. And that's done over here in an actually already rather old study that I did together with Michael Helle in Kiel University in Germany, where we labeled in this meningioma patient the different arteries. And you can see, if we zoom in, and that the brain tumor was actually fed by two different arteries, both the left internal carotid artery, but also the external carotid artery. And this kind of information can be important if you're thinking about interventions. Another example, this is again using ASL as a dynamic angiography sequence where we only label a single artery, and you can nicely see that we also then see a single artery of the single part of the arterial tree. This is an example with a patient with an AVM on the left-hand side. These are the time of flight MIPS, and these are the selective ASL angiography sequences. And if you then look at the AVM, you can see that it's both fed by the left and right internal carotid artery, but also the vertebral artery. So by selectively labeling, we get more insight in the different feeders of such an AVM. And of course, you can add them together and get these kind of color representations. So this is what I always find a very nice example, again, in a study that I've done together with Michael Helle in Kiel, where you also see the AVM here on the time of flight. And we now labeled these two feeders of the AVM. And if you look over here, then actually we see that also still brain tissue is being fed by both of these feeders. Now, after intervention, you can see that the AVM is now gone. There was glue put into the AVM. You can actually see that this brain region that I now encircle with my pointer is now fed by the red artery, whereas before intervention it was being fed by the green artery. And that was very informative actually for understanding the complaints that these patients actually developed after the intervention. Because actually this region that switched from one artery to the other was actually Wernicke's area. And this patient actually developed a speech order that actually resolved after a few weeks. So apparently the brain had to adapt again to this kind of different feeding. So you see that these kind of different super selective images really can give you additional information. And we also validated this approach with like comparing it to DSA. And then you also can see that we actually can label smaller arteries than they can achieve with DSA. So the last technical development that I want to describe is that we are seeing that a lot of groups are now trying to actually map blood-brain barrier breakdown without using a contrast agent by looking at the water transport across the blood-brain barrier. And so we all know that there's this blood-brain barrier with these kind of tight junctions, and we know that it's protecting our neuropil from large molecules going from the blood into the tissue. However, water can actually quite freely cross over the blood-brain barrier, both via the tight junctions, but also via the membranes. And so the water can actually use different kind of routes. Now with ASL, we are of course creating label that will enter the capillaries, and then this label will cross from the blood into the tissue. And we know that almost all label will cross within this kind of 2-3 seconds into the tissue. So by monitoring how easily this water crosses from the blood into the tissue, we can maybe get an impression of the blood-brain barrier integrity. But to do so, we have to differentiate. We have to know whether our label is within the blood or outside of the vasculature. And we can actually do this in 2 different ways. First is that in a multi-echo sequence, we can actually measure the T2 of our ASL signal. And you see that with longer echo time, you see a decrease in the signal, and we can fit a T2 to this. Now, why would this give us information on where the label is? Because we know that the T2 of arterial blood is like 160 milliseconds, of venous blood is 50 milliseconds, and a tissue is approximately 90 milliseconds. So by measuring the T2, we can know where our label is. And that's what we can do. Again, a multi-echo sequence. And now it's also, again, a multi-time point sequence. So we have a short delay time. You see that our label is still in the vasculature. And then we wait longer, and you see already visually that the label is spreading into the tissue. And then we measure it at different echo times, and we can calculate the T2, shown on the right-hand side. And now we see that the T2 goes from the red colors, so 180 milliseconds, to the blue greenish colors, showing that's around the 90 milliseconds where we know that the label has crossed into the tissue. So we see that by looking at the T2, we can actually determine where the label is. Then we can throw this into a two-compartment model, and we can actually provide a fit to the data that gives us a map of how long it takes for the blood to actually go from the intravascular to the extravascular compartment. And that's shown over here. So this is the first technique, how we can differentiate intra from extravascular signal. There's a second technique, and that's really mainly being pioneered by Qingfeng Xiao and Danny Wang in California in the US. And they are actually using diffusion-weighted ASL. So they use diffusion-weighted gradients on top of an ASL signal. If the label is still in the vasculature, it's flowing quite fast, and therefore you will see you only need very weak diffusion gradient to crush your signal. If the label goes into the tissue, it will be more or less at a single location, and therefore you would need much stronger gradients to crush the signal. And then you can also get a timing map. So the group of Danny Wang and Qingfeng Xiao have done this in Alzheimer patients. In healthy older subjects, and they correlated with amyloid beta, so more in the kind of earlier stages of Alzheimer's disease. And what they actually were showing is that the amount of amyloid beta in the CSF was correlated with this kind of time it takes for the blood to cross the blood-brain barrier. And so saying that there's some kind of link between amyloid beta accumulation and the blood-brain condition or the water transport across the blood-brain barrier. And this is another example that is actually giving us additional information with two tumor patients, where in a collaboration with a group in Munich, we actually measured this timing where we see that actually in the brain tumor, actually the water transport across the blood-brain barrier was much faster, so shorter transit times. And that's what you also see over here. In a tumor, we say the water transport is faster over the blood-brain barrier. So that looks very fine, and it looks great, but now I'm going to tell you a little bit about the kind of nice thing about research, or also the sometimes annoying thing about research. And that's based on this study from Catherine Morgan, who actually used these two different ways of measuring the water transport across the blood-brain barrier. And they've done this in a cohort of people with different age. Now, if they look at people growing older, you see that the CBF is decreasing. If we measure it with the diffusion approach, if we use the T2 approach, we also see the blood flow is getting lower when we grow old. We also see a trend to a slower arrival of the label in our brain. So this is still giving more or less the same results between both techniques. But then if we're looking at the water transport, we see actually very different findings. With the T2 approach, we see a higher KW, and KW will tell you that it's a faster water transport across the blood-brain barrier. And so we would interpret this as a more leaky blood-brain barrier. However, if we use the diffusion-weighted approach, we see actually a lower KW. That means the water gets less fast across the blood-brain barrier, what we would explain by a poorer aquaporin performance. Interesting these two techniques give opposite findings and we don't understand why. So this is one of the kind of burning questions in our community. Okay, so the final 5 minutes I want to spend on some of the examples that is showing in this review paper by the Perfusion study group, who looked at the current state and guidance on the use of ASL in clinical neuroimaging. And you will see that we're getting back to this kind of, for me, crucial question about the arterial transit time artifacts. And so this is a first example. This was a woman who just gave birth, and she was coming in with complaints about headache and I think also dizziness and nausea, and she had a normal CT scan, and they actually it was negative on the CT scan, and they measured the ASL with these in this woman, and they actually saw this kind of transit time artifacts all over the brain. And that's not normal. And this is a woman, I thought she was like 36 years old. You would not expect to see this kind of transit time artifacts. So they actually went back to the CT angiography and the DSA, and actually they saw the CT angiography, and they actually saw this kind of multiple constrictions of vessels that were originally missed. So the ASL gave rise to looking for this kind of stenosis, the constrictions on the CT, and was found, she was treated, and then actually these constrictions were resolved. So you see that these kind of artifacts can give you a big clue on how to look or where to look for pathology. And that also happens in these acute stroke examples, where in the first patient on the ASL scan, you really don't see any kind of label. Also not in the vessels that are feeding this region. In the second subject, you actually see that there is label in the brain feeding vasculature, which tells you that there is still blood going on the way. So there are probably good collaterals in this subject, but it gives rise to delayed arrival of blood. So again, you see that this kind of arterial transit time artifacts are giving you important information about the condition of your patient. So this is another, what you can say is an artifact. And we see this kind of enhanced signal in the sinus. And this is actually coming from a kind of shortcut from the artery to the venous side. Oh, sorry, that was too quick. What also was seen on the DSA afterwards. Again, you see this very hyper-intense signal that shows you somewhere there is intravascular signal. Let's see where it is coming from. Then I think, and this is probably one of my last examples that I'm giving to you, this is a follow-up on a grade 2 glioma, where you see actually a slowly increasing perfusion signal around the surgical area, and you see that clearly the perfusion got more perfused, which is actually showing of recurrence of tumor, and that's why they started radiotherapy and TMZ treatment in the subject, and then they actually also saw that the perfusion was actually decreased. Now, this is of course one of the other advantages of ASL, is that you could also think about whether in some cases you actually can not give contrast agents. We can, ASL is using the blood itself as a tracer and therefore is less invasive. Now, this is the final example, I think, where you see in an epilepsy patient, you actually see during the epilepsy attack, we see increased perfusion with subsequent pathology. So take-home messages. I hope I've shown you that ASL is actually a very versatile technique, that we can get much different information about the hemodynamics in the brain. We can use it for dynamic angiography, but also for quantitative perfusion MRI. And both have a role in knowing what's going on in our patients. We can also use multi-time point ASL to even get a better visualization on how the blood is feeding our brain tissue. In research settings, we can also label a single artery, which gives a flow territory information, which can also be very helpful to understanding the hemodynamics in our subjects. And current research is looking at whether we can use ASL as a non-invasive way of getting information on the blood-brain barrier status. I would say that this still needs further validation and interpretation, especially because of these kind of conflicting findings between the diffusion approach and the T2 approach. Then the big advantage of ASL is completely safe. That's of course very good because maybe you don't always have to give contrast agent. Of course, the post-contrast T1 is still such an important scan that I know it's difficult to give less contrast agent. For me, as an MR physicist, it's very nice that it's completely safe because we can develop these new techniques and test them on ourselves or on normal volunteers, but also think about pediatric applications. And maybe at least for pediatric patients, we can use less contrast agent. Recognize arterial transit time artifacts. They are a curse and a blessing. We don't like them because they're not giving us perfusion values, but actually they give us a lot of information. So see them also and treat them as a form of information when you're looking at ASL scans. Now, finally, I want to thank you for your attention. Also thank all my colleagues in the Gorter Center. In this case, I would especially like to thank Elena Václavou, a postdoc in my group who is doing a lot of ASL developments and from whom I have also stolen or got a few of the slides that I've been showing you. With that, I'm very curious whether you have any questions or any kind of feedback, and I will stop sharing to see also you.
Okay. Thank you so much, Matthias.
Thank you, everyone. Thank you, thank you, thank you. Please, can we unmute and give a round of applause to our speaker?
Thank you.
Yeah.
Thank
Hello.
you very much.
Yeah.
So today we have learned about arterial spin labeling, how useful it is. It's absolutely safe. Dynamic angio, quantitative perfusion, dynamic perfusion, water transport across blood-brain barrier. We can use it for stroke, we can use for AVM, we can use for a lot of CNS pathology. Yes, thank you. So can we clap for Professor Matthias once again? Thank you very much. Thank you, thank you. So please, if you have any questions, could you drop it in the chat box?
Yes, Uyi, thank you so much. Uyi, let me just make a comment before the question starts coming in.
Okay, Prof.
Good morning, Matthias. Okay, thank you so much. This is Godwin. Really lovely lecture, very extensive. Just want to say thank you for a beautiful presentation and for your team. Just a quick one to say that it appears that what you have shown shows us that ASL has several applications and can be used in diverse clinical settings. But I see that even in the advanced countries, that it is not as widely used in the clinical setting as one would have assumed. It's still used mostly in research settings and maybe in more advanced centers. Is there a reason for this? The second question I have is that in terms of the artifacts, apart from just looking at the value, the quantitative values on the side, are there other things one should look out for to avoid, making mistakes in terms of artifactual interpretations and things like that. Thank you so much.
Yeah, thank you for these great questions. Maybe I'll actually share my screen again. Yeah, regarding your first question about why is it not being used more? First of all, and okay, I'm just going to leave it a little bit on this slide. First of all, I think, for example, radiologists also in our countries are frequently quite conservative in adopting new sequences, and there's a big pressure on scan examination duration. So I think that's one of the hurdles of getting it accepted. For example, in brain tumor imaging, there's something different going on, because in brain tumors or in tumor imaging, we are almost always giving contrast agents for the post-contrast T1. And then the argument is very quickly that if I inject a contrast agent, I can also make a contrast agent-based perfusion scan to get the perfusion. The interesting thing is that in our hospital, we actually, for quite an amount of time, we actually stopped doing the contrast-based perfusion imaging, but only the ASL imaging. Also because the images, and now I'm just showing you an epilepsy case, but it's just for illustrative purposes, is actually very easy to interpret. It's quite a nice white matter, gray matter contrast. Whereas in the contrast agent-based method, you actually see the image is much more difficult to interpret. So in that sense, ASL was actually preferred over the contrast agent-based method. In the end, we have decided to again do both. So you see that it's still not replacing then the contrast-based methods. So that are, I think, my main observations. The interesting thing is that if you talk to radiologists who start using it, and especially in patients in which it's difficult to make a diagnosis, they actually say that, for example, for detections of AVMs, but also other kind of pathologies, that actually it did help them in the end. And once they understand also this balance between the arterial transit time artifacts, that they actually are a source of information, that's when they really started to see the benefit. Maybe the third and final reason is that I think the planning of the ASL sequence is sometimes a little bit more complicated, or people are more afraid for it. That's why we are, for example, now also looking at automated planning to actually solve that. So your second question was, and that was also why I was putting on this a slide with an ASL scan, how should I interpret these images and how should I be sure that I'm not looking at an artifact? Now, if I'm looking at a clinical case, the first thing that I'm looking at, do I see a nice white matter, gray matter separation? Do I have a good labeling efficiency, which gives me enough signal in the gray matter, and that's seen as this kind of gray matter, white matter contrast? Then I'm going to look at, do I actually recognize the flow territories in my ASL scan? If I see the big ICA or posterior flow territory, the complete flow territory being hypointense, I'm going to worry about two things. Is there a stenosis or an occlusion in the main brain feeding artery, or do I have a labeling problem in one of the arteries? So that will be my second thing that I'm looking for. Then the third thing is that I'm looking at the border zones between the flow territories. Are they nicely showing signal on my ASL scan? If they are hypoperfused, I could again have a problem that not all label has arrived in the tissue yet. Then the third thing that I'm looking for are these kind of hyperintense arterial transit time artifacts. Do I see them? Are they for the whole flow territory? Then the whole flow territory is delayed. Are they more in the tissue? Then I'm thinking more about an AVM. And for example, ASL has been shown to be very sensitive in picking up also micro IVMs because we see this very bright signal on the ASL scans. And now I'm saying good afternoon to my office mate. So that is, I think, how I would describe how I look at these ASL scans and determine whether or not they have good quality. Oh, maybe I should mention one more, motion artifacts. And that will give you very distorted ASL scans. And frequently you already immediately say that is not interpretable. Does that answer your questions?
Yes, thank you so much. Very extensive. Thank you so much. Highly appreciated, Matthias. Thank you.
You're welcome.
Thank you very much, Professor Godwin. We have one more. I have a question. Is this only possible with 3 Tesla and above MRI scan?
Very good question, and the answer is no. Also on 1.5 Tesla, actually ASL is working quite well. You maybe want to use slightly thicker, lower resolution readout. We would typically decrease the resolution a bit, but then actually also on 1.5 Tesla, you get reasonably well ASL scans. Recently, we have actually also been measuring it on an 0.6 Tesla scanner, and even there we got some signal, but there you really see that your SNR becomes limiting. Now, why does the SNR depend so much also on the field strength? Of course, we all know that stronger the field, all our MR images gets a higher SNR. But with ASL, we also see that the T1 of blood is longer at higher field strength. So our label is actually not decaying that fast at 3 Tesla compared to 1.5 Tesla. So we would prefer here in Leiden, where we both have 1.5 and 3 Tesla, we prefer the 3 Tesla, but 1.5 Tesla can also be used. And I also saw the question in the chat about 1.5 and 3 Tesla. Yes, of course, the vendors are always asking money for the ASL kind of packages. And that, of course, increased the cost. And that's, yeah, something I'm sorry that I can do very little about. That's the way that the MRI vendors are gain their profits or make sure that they can get back their development costs. In that sense, if I would have a 1.5 and a 3T, I would only acquire a license for the 3 Tesla scanner and not for the 1.5 Tesla. And I see another question. I'm not sure whether I can continue about using ASL for functional imaging, because I like that question a lot. I also want to answer that one. If you want to do fMRI, normally I would still advise bold, especially if you have like your activation and your rest condition very close to each other. So think about a language task. If you're reading words and intertwine this with a rest period, bold is the best way to go. However, if you are interested in different states of the brain that you cannot interleave, think about, I'm interested in, for example, where is the brain functioning during sleep deprivation? And you cannot switch very quickly from a sleep deprived to a well-rested state. You cannot switch between, say, 30 seconds. That's a kind of condition that bold is not doing very well, and ASL can actually be used. Also, we have been looking at the influence on certain pharmacological substances. That's also where you cannot switch very quickly from the activation state to the rest condition. Also there you can use ASL. Otherwise use BOLT.
Thank you very much. Thank you. Any more questions?